course, my friend Dai. You saw his full bio but one of the things I want to say is that in a time where so much in the world is changing, both of us, we'll hear his background, work in development space and anti-poverty space, we're constantly thinking about and evolving. The world has changed a lot in the last year for our space and our sector. And as we are constantly in rooms thinking and being innovative about how not only do we respond to fundraising gaps, but how do we deliver services better, partner with people around the world so that communities thrive. And the cool thing about Rotary is we're all about communities thriving, working together, building that friendship and building that fellowship. So Dai is the person that comes to mind every time someone says, I need a good thinker in the room to think outside the box, who will tell it like it is, and make sure that you have great ideas there. And that's who he is. He is unapologetically honest. And yeah. And the cool thing about that is it just clears the room. It's like, let's just say how it should be and let's not, keep going around in circles on things. So I met him when I was working at Management Sciences for Health, which was a health system strengthening organization that was very much trying to take what now is very normalized, but take something that in a space that was really focused only on babies and try to say, well, babies are great, but if babies don't have systems, they don't have vaccines, they don't have a health system, they don't have a health workforce, none of this matters. We spent a lot of time doing that. He was able to convince partners, governments, donors, all of those people the right way and the right way to do those things. And so I admired him for so long. Like I said, I love his honesty. I love having him being in a room with him, especially when he gets annoyed, because it is pure fun. But with that, Dai, I am so excited for you to come up and share his, so his organization recently changed names. I will look at it again. Health Systems Insight, to come forth and tell us about innovations in the space of maternal child health.
Hello, everybody, and thank you very much for having me here today. My name is Dai, and I am joined by Jen, who is our Chief Operating Officer for the Health Systems Insight. It's kind of rare these days that I get to wear a suit, but when I wear a suit and I go to the airport, everybody asks if I am flight attendant. Although that used to be my dream job, but then I am not working as a flight attendant anymore, but I have never worked as that. But I am actually working as a president of the Health Systems Insight, which is a US-based nonprofit organization. And I'm really happy to be able to introduce our work in general, but then also that our flagship fellowship program, which is to work with young women in the low and middle income countries, to make them to be a next generation of the leader in thinking around health financing, which we are really strongly feeling about. The Health Systems Insight is, as I mentioned, the US nonprofit organization. We work very closely with various governments and then also a local academic institutions and partners. Working in Asia and Africa, like the Philippines, Indonesia, Pakistan, Kenya, Mozambique, and Burkina Faso, we have offices, and I'm mainly working around the health systems, but then I will talk a little bit more about our focus. Our vision is that the health systems, not yet, sorry, can you go back? Yeah. Our vision is that the health systems everywhere are resilient, responsive, and then equitable, and delivering high quality of the care. So we really are the specialists in the health financing space. And then as you can imagine in the current United States debates, but anywhere in the world, that the money really determines the how the health services are being delivered. And then also that we want to make sure that the people who do not necessarily have the affordability to be able to access to the care. So our work is to make sure that those resources, it can be the human resource, it can be the financial resource, or it can be the commodity resource, like the medicines or drugs and then diagnostics, can be mobilized and managed and then also being used and measured. And then some of the examples that I'm going to give in short manner, shortly from Kenya, but it's very important to think is like, for example, I go to grocery store And then I had a budget for my grocery shopping for this month. And then maybe let's say like I have $400 for this month, but then how do I spend the money has to be very strategic, especially these days that the groceries are very expensive. So do I want to have everything organic? Because so my objective of the grocery shopping can be organic, healthy food. Or maybe like I like to have this kind of like a revived beef stew. Then I want to see that the more luxury food. And then how I allocate those $400 and then where to spend, and then making sure that we reduce the wastage of the grocery are really critical for our sort of a day-to-day life. And then that's exactly same in the health systems and healthcare. With the government or you have the health budget, and then we want to make sure that within those health budget, we will be able to make healthcare very, very affordable. And also that if you go to the healthcare facilities and a hospital in the States or anywhere in the world, you would wonder why there are so much wastage there. And then also why do I have to go so many steps in order to get the treatment? And then so where do those kind of wastage exist? And then how are we going to reduce that? And then helping those governments and then partners and then national health insurance agencies to understand those kind of insight is the work that we do. So I will talk a little bit about the example from Kenya now. In Kenya, one of the issues, and then I understand that the Rotary International and the Rotary Club have been dedicated to the maternal care in many of the countries. And then one of the biggest hurdle for the mothers and the family to access to the maternal care is the cost of the delivery and the cost of the care. It can be really catastrophic for family of the lower income areas to have a baby delivered at hospital because of the amount of the bill they have to pay is going to be enormous. So Kenyan government made a really bold decision few years ago to make all the maternity service for free as a part of the national health insurance. So as far as if you are enrolled in health insurance, which is also free, to be passed in, and especially for the mothers and women to get enrolled. And then the maternal health care will become free for everybody. So that was the policy decisions that the government made, which we all applauded. But then did it really work? So we are tasked to work with the government in understanding that these policy decisions have actually helped the women to have the maternal health care services access better. I have access to the paper, and then if you're interested in, I'm happy to share the actual paper that we came out from this work. But what's really happened was, in one of the hospitals that many people go, the expected revenue from delivering the babies from the normal delivery service was about $100,000 a year. So if everything goes well, and then if all those mothers can deliver the baby, the hospital will get reimbursed for the $100,000 for their service. But in reality, in the 2018 and 2019, they only got the $10,000 reimbursed. So $90,000 out of the $100,000 was lost revenue for the hospital. So what just happened is that the really critical consequence to the actual mothers, because hospitals do not want to provide a free service, or they cannot afford to provide a free service. They have to provide the medicines, they have to put the bandage on, they have to give the shots. All those expenses, somebody has to pay for it. So even though that the national health policy says that the maternal services are supposed to be free, because of this execution of the policy, women still have to pay quite a bit of out-of-pocket expense, from their own money to get to that test. So at the end that the policy didn't really do what they wanted to see done. And then we got some of the quotes from the local provider. So this is a statement, or this is like a quotes that we got from the local providers or organizations. Several women who deserve free care are not getting it because essential commodities are not available. when you have to tell women to go and get the bucket, because bucket is important in those settings to wash things and then clean yourself. And then also get the spoon, because in order to get the fed by the food while you are at the hospital, something has to be there, the utensil has to be there. And then consumables and then the food. And then it ceases to be a free service anymore, right? So I think that what we needed to do and what we had successfully worked with the local government is the following issues. What I want you to a little bit take on to thinking around is working on the maternal health services and access is very important. And then in it is the health financing and then the expert opinion analysis like ours to be able to provide can make it actually to work. So what we did was the analysis of why the money doesn't flow. And then what we realized is that the insurance claims submission process was so cumbersome. And then people could not make the decisions of when to submit and how to submit. So the hospital was only submitting 25% of the claims from the 100% of the claims. So that's already a problem. And then the National Health Insurance Agency did not have the capacity to process the increased number of those claims. So they could not also provide the services to create a funding flow to make sure that the money get there. And then also that the women and the family are not necessarily aware that the free services you needed to be enrolled in the national insurance. So they may sometimes miss the registration even though that's free for those women. That did not happen. So all those things actually created in execution of the government policy, which was really that important. And then by working with the local government, we could actually increase the number of the claim submissions by 3-fold. And then also that we increased that we decreased the number of the women's cases which ended up in the outpatient and out-of-pocket expense. So what I wanted to highlight is that the health financing and talking about the money sometimes in the healthcare can be a little bit like a red flag issues, like people don't want to talk about it, but that's a really critical, and then it really makes the difference. Yeah. So that's the type of the work that we are currently working on. And then another one that I wanted to show this graph is the another area of the work is for the development assistance in health, like a high-income country like the United States. I'm from Japan. France, Italy, and all those countries provide money to improve the healthcare in the low and middle income countries. And then we have seen that the very steady growth of the investment into a healthcare development from 1990s to about 2015. And then actually the amount of the money jumped around the 2020 and then 2021 because of the COVID pandemic. So everybody started to get money. But once the COVID is done, money disappeared. And then 2025, not just the United States, Europe, and then also multilateral organizations, many the wealthy countries reduced the contributions to the health improvement. So now that many of the government who needed to rely on those kind of funding are now really faced with the financial challenges. And then the work that we are doing, and then we want to really put more effort into it, is to make sure that the government can prioritize what matters the most. Because my experience as a Japanese is that the Japanese likes hospitals, not the primary healthcare center. So when we have the money, we want to see everybody spend on the hospitals. And then I think that happens in the many countries, and we don't want that to happen. We want to make sure that we can provide the information so that the government can make the decision to make sure that the primary health care and the most needed care are being provided, including maternal care and immunizations and others. So in that way, that our work, I think, is very proud of, and then I'm very passionate about, is that the health financing actually matters. I want to then talk a little bit about our fellowship program as related to this one. Our fellowship program is named Samia Stomo Memorial Fellowship. Samia used to actually assist at the Rotary Club in Massachusetts, and then she joined our organization at the age of 23, and then she was a really passionate person and worked on the making sure that the women get the universal health coverage access. And then that was a real hard driver. Unfortunately, she passed away when the Ethiopian airline crash happened in 2019. She was actually traveling from Ethiopia to Kenya to work on the issues that I just presented. So based on that, so after that, her death, that we decided to, the organization, at the time I was not still with the organizations, but then at the time that the organization decided to modernize her by creating the fellowship program for the young women in the health financing space. We created the Samia Rose Stomo Memorial Fellowship. I think that this is to provide a training opportunity for young women who wants to be a health financing specialist. The reason why I think this is very important is that representation where the women are not women are most affected is really important, right? So that the health workers, when you think about the nurses and the health workers, they tend to be women. And the number suggests that the 70%, more than 70% of the healthcare workers are women. But when you look at the leadership, only 25% of the leaders are women. So we want, especially that's strong in the health financing space, that it's very male dominated decisions. So we want them to influence that. The second part is that the women's reality, I will give the very stark reality of the women and then health financing issue in the next slide. But women's realities are not really reflected in the healthcare and then health planning by the government. So we want that to be influenced. And then also that we realize that the women, the professionals who wants to get the more educations and then also professional exposure and the less opportunities than the male counterpart. So this fellowship program is it's a small program, but our efforts in addressing these issues. We have so far included 14 fellows for the last 4 years, covering the fellows from the Philippines, Indonesia, Kenya, Bangladesh, and then Burkina Faso. And then for the last year, we covered 3 fellows from Kenya, Pakistan, and Indonesia. And then we just starting a new fellowship program. We have 3 fellows. They're going to get work with us for the 6 to 8 months. And then they will be embedded into our project, and then they will directly work with the people who are working with the government. And then one-to-one mentoring, and also about $1,000 per month of the stipend to support their day-to-day work. And then also we also provide lectures every 2 weeks, give the lectures on the global health and then project management so that their professional brand is established. So I want to talk one example from one of the fellows. So this is Saima Amin. She's from Peshawar, Pakistan, and then she was the fellow last year. She had a master's in science and environmental science, but then her career goal was to inform decisions on public health policies through researches for fair health systems. And that's really aligned with our organization's mission. And then her study project was the cost of being a woman, and then she looked at the gynecological mobility and then out-of-pocket expenses in Pakistan. But I just want to make sure everybody know where I am talking about. That's Pakistan. It's in between India and then Afghanistan and then Iran. And then Peshawar is in the pink area. Actually, I lived there for 2.5 years. And then I also want to thank Rotary International because that's 30 years ago when the Rotary International actually committed to the polio eradication program. And then I was the first batch of the polio expert to Pakistan. I actually went to the village and then working with the teachers who are giving the drops to the children. So, and then for the 3 years I was there doing that. So it's really appreciate that the Rotary continuing to commit to the polio because sometimes the donor only commits for 5 years, but then this longevity of the commitment really makes a difference. So thank you. But anyway, so that's the area that she's working in. And then she showed some of the photos of the women. These are the women that the work that are living there. Actually, that's not very different from the time that I was working there. This is me in the middle from 1993. I just arrived in November. I just arrived in Peshawar. And these are the doctors that we did the training of how to diagnose and then treat diarrheal diseases in Pakistan. So that was me, and then that's how my career started. Hard work is really eye-opening for me, even though that I was there for 3 years. That my access was mainly to the men's world, not too much to the women's world. So that maybe that the case is very important is this Rabia's story. Rabia is the mother of the 4 children, and then she lives in the rural area. She has been struggling with the very painful pelvic infections, chronic infections for the last 4 years. It started small, but then just getting to the village doctors didn't really do anything for the treatment, and then she continued to have the chronic pelvic infections forever. So she and her husband finally decided to take a bus to Peshawar to get to the hospital to get actual treatment. But then at the same time, what happened is that the road to the city for women is sometimes very tricky in Pakistan. And then also that she has already 4 children, and one of the children is the Down syndrome. So that she was worried about who's going to take care of them. And then also that the husband has to take the unpaid leave in order to take her back to the hospital. So this whole thing's created the financial anxiety and then challenge, but then also access to the program that she shouldn't have program, right? Like the 4 years of the pain from the infection. As a matter of fact, that this fellow has found that the 20% of the women between the age 18 and 44 has had the pelvic or gynecological programs, and they have sought for the paid the services from the clinics. And then most of them relied on the outpatient clinic because inpatient clinic can be inpatient services can be expensive, and then they have to take off. So they looked for the outpatient services. Unfortunately, those outpatient services cost about $50. And then the living wage for the household is only $4,000 per year. The $50 of the outpatient visit is very expensive. And then Pakistan does have the national health insurance scheme, but it only covers inpatient care, but not the outpatient care. So if they had chosen the inpatient care, maybe that the financial shock may have been lessened. But then because of the 85% of the women chooses outpatient care, they're ending up paying out of pocket in order to access. But the most important, I think, finding for me from this fellow's study was that she found that the district, where that manages all those health services, never consider the gynecological program as a priority, even though that's the 20% of the women complaints rather than having a program. So the women representation is very important there. We have 2 other fellows that which did a similar study, and they also found a very interesting findings. Those are all. I'm going to show you the link to our website, and then you can actually download these reports. And they actually had a really insightful findings, like women's headed household has more power for the women to decide healthcare decisions, but they don't have money. Men headed household, women has to consult and then give the decisions power to the husband, but they have much more money, and then how we going to balance that? And then all those tricky questions are there, and then those are all the things that I think we feel very passionate about. So that's the program the fellowship program that we are working on. And then this from one of the fellows that I thank the fellowship team and everyone who believe in power of their awareness and be the change. And then I think that this is really powerful for us. And then that's the investment that we want to continue to make. That's the link to the, I'll give you my card and then you will also have the QR code so that the people need to do that now. But if you could support us in the fellowship program to expand the countries or like the people, I would really appreciate. But then even just that the downloading those reports and then asking us the questions and if we can talk more about this topic, I would be really happy to do this. And then I'm really thank you for the opportunity to introduce our work. And then, by the way, finally, I'm also birthday next week. Yeah. Thank you very much.
I saw you deal in the Philippines.
Yes,
Where do you headquarter in the Philippines?
in Manila. Yeah.
You're in Manila.
Yeah.
How large of a practice do you have in the Philippines?
We have 7 staff members at the moment, working mainly with the national health agencies and the Ministry of Health.
So you deal with the government,
Yes.
and you haven't had any problems with them.
No, because we haven't had because our work is not to give money to them. I guess that our work is to provide analysis and then results to the government and then have the discussion.
What's your budget in the Philippines? Your budget in the Philippines?
About $300,000. Yeah.
And thank you very much for what you're doing. Appreciate it.
We are fortunate to be able to work with the National Health Insurance Program in Pakistan. Most of the countries we work is pretty rough. To be honest, like Burkina Faso had a coup. That while we are still there. They had 2 coups. Yes. And then Pakistan, we had a shooting when I was there, and then jail was just there. So, but then it kind of makes it a little bit more adrenaline rush and exciting. But the Philippines, we have been really established a great relationship with the national health insurance agencies in a way that we have been able to analyze their data to be able to provide more insights so that they can navigate their financial situations better. I think that our one thing that I want to say is our organization, for example, we are based in the United States at the headquarters, but we only have 6 people in the United States. And then almost exclusively, all our program in the country are led by the country experts. And then they understand those politics, and then they understand the navigations and how to present a better way. So we have been relatively program free in terms of like providing the services.
Here, one more. Here, next one.
Yes.
Thank you so much for coming. You have a broad international experience, including with the United States. And Crystal says you tell it like it is. Is it the truth?
Yeah.
So I want to ask you about your views on the Affordable Care Act compared to, say, Europe or Japan or Canada or these other places that are the gold standard for healthcare.
Thank you for asking me about that. Coming from Japan, which we have a national health insurance since 40 years now. And then also, in addition, we also have a government-run long-term care, so that especially for the elderly. So it's about $25 per month. Everybody up 40 years old and above have to contribute, and it's less than $25 a month. And then everybody will get the support depending on your age and then also disability levels. So not just the health insurance, but then elderly care insurance is also publicly managed. And from country coming from the access to the healthcare, and then somewhat like an ease of access financially. I don't quite understand why United States and then Americans are so much debating about like a fundamental rights, to be honest, it's just like a health. Everybody will have some kind of health problem. One time I had somebody, very wealthy person telling me that why do we have to subsidize the poor people's care if the poor people making the wrong decisions for their health? And then I was a little bit speechless first, but then said that those kind of like a life choice related disease may be there, but then there are also other issues that then you may be also the subject to all those diseases. So like if you, just because you are wealthy and then you can be exempted from all those agonies and pains, and I think you was my answer. But anyway, so that's how I view, and then I hope that it is painful, and then it's really strange and then difficult to understand for me that why healthcare has to be corporate business, and then why the healthcare has to be debated as a part of it. But anyway, that's not.
Good answer. Yeah.
Is that a good answer? Yeah.
We're gonna plant a tree in your name.
Oh, it's
Yes. And this is the wonderful certificate. Let's you and I take a photo.